Please welcome Dr. Aaron Sasson.
Thank you. I'd like to thank Marianne and Bob for the invitation and opportunity to speak to you here. And although I spent about 15 years from Nebraska, I grew up in New Jersey, so I have the East Coast speaking down. If I speak too fast, please let me know. I'll talk today to you about surgery for neuroendocrine tumors. I have no conflicts or disclosures to mention to you. Obviously, as Hal discussed, can everyone hear me? A little louder? Okay, whoa, okay, that's a little loud. Okay. I've never been told to speak up before, but okay, I'll speak up. Okay. So neuroendocrine tumors are a diverse tumors. They can occur almost anywhere in the body. And so, a lot of patients come to me and say I have a neuroendocrine tumor. And obviously, I think the most important facet to determine is what is the location? What are they referring to? You have tumors in the thyroid, you have tumors in the lung, adrenal gland. All these are neuroendocrine tumors. But we're going to focus today on the neuroendocrine tumors that arise in the GI tract, my area of expertise. And of those, probably the two most clinically relevant, or the two most common, or the ones that get the most attention for a variety of reasons that I can discuss, is going to be the pancreas and the small intestine. The small intestine is what we would refer to in the past as carcinoid tumors. Now, but you can see, though, that there's still a lot of tumors that occur in the appendix, in the colon, and in the rectum, per se. They tend to be not as significant. They tend to be more like in polyps or smaller and don't play as much of a role. And the surgery that we do for these patients is typically involved for the pancreas and pancreas and small intestines. I can talk about the stomach, but they are really a more of a rare offshoot of neuroendocrine tumors, and they have specialized, very different treatment algorithms than almost all the other neuroendocrine tumors. I think this slide is probably the most important slide that I ever show people, or when I speak to doctors about neuroendocrine tumors. Nothing more important than the proper pathology classification of the tumor. As a matter of fact, probably one of the greatest significant advances in neuroendocrine tumors that occurred without people even knowing about it is this slide, and how pathologists have now properly classified these tumors. Now, it's important because this then tells us on what options are best for patients. The better we can group and the better we could identify the characteristics and features of the tumor, the better then the treatment options are for you. So this is probably one of the most important slides, and we can't do anything. We can offer no sound treatment or intellectual opinion without knowing the features of the pathology results. On top of that, it's important to note, and this is why no two patients are alike, because no two patients have the same pathology. Pathology can change, and unlike other cancers where once you determine you have a cancer, maybe it has spread, you don't have to necessarily do another biopsy. But for these neuroendocrine patients, sometimes we may do another biopsy a year or two later because these tumors can change. They're not as homogeneous as we like to think. There's a little heterogeneity to them. And today I'm going to be focusing on the well-differentiated low and intermediate grade, because those are the ones that are the most common, and also the ones that we have probably the most knowledge about. We can answer questions about some of the other grade 3s and the high-grade neuroendocrine carcinomas in the Q&A if you'd like. I show this slide because this is, for the most part, almost all of the treatment options that are available for patients with neuroendocrine tumors. And you can see the list is quite long. From observation, there aren't that many cancers when you get diagnosed that one of the options is watching. almost all the other cancers, for colon cancer, breast cancer, lung cancer, there's a treatment modality for you, and people then go on and act it. There's no oncologist that would say, oh, you have a lung cancer, let's watch it. They're going to offer you a treatment. But surprisingly, for neuroendocrine tumors, observation can be a viable option. I'll discuss that when. We have hormonal therapy, we have targeted therapy, we have liver-directed therapy, chemotherapy, even radiation therapy, and surgery, and I'll discuss the surgery part. But these are a lot of options, and we have all of these in our armamentarium. And so you can imagine that the combination of options one may employ for a particular person can be quite varied. So you take that along with the variety or the diversity of the tumor location, the diversity of the tumor pathology, and the multitude of options. It doesn't take a mathematician to realize that the possibilities are endless, almost an infinite number of options available, which is why, as Hal had mentioned, some patients come to us and they've gone to other doctors and they may see 5 doctors and they get 5 different opinions. And it's because of the diversity, the heterogeneity in philosophy, and we'll discuss that a little bit as well. So how do we go about determining which of these options is going to be right for each patient? And so this is some of the factors that I use and some of the factors that colleagues use. Obviously, in my mind, symptoms and hormone production are paramount. I think it's vital that we improve patient symptoms, and I'll show you some slides about that as well. Obviously, next comes general health status and the health of the patient. A patient who comes to me who's on dialysis, who has oxygen because they can't breathe, has limited options in terms of surgery. If they can't tolerate the general anesthesia, then surgery does not become a viable option for them. We do have other options for them, and I'll touch on them or allude to them and be happy to discuss them in the Q&A portion. Next then comes, of course, tumor burden. And these aren't in order, by the way. These are just put down as a list as I thought of them, or as they were published. Is tumor burden. How much tumor is there? Is there just localized tumor in just the organ? Has it spread? And if it has spread, what organs has it spread to? Are those organs critical? So those are the factors that go into determining options for you. Then, of course, which we will hear about later, is what kind of uptake are they showing on our dotatate scan? Histologic features, tumor growth, and age. I typically try not to make age a factor with regards to cancer treatments, but I do take age into a very important characteristic for this tumor, and I'll show you why with some case scenarios shortly. I like this slide because it comes from an international group for neuroendocrine tumors, and it has what are the goals. And so whenever I meet a patient, I try to determine what are the goals. What are the goals of we're trying to achieve when you come to see me? Obviously, we want to try to either remove the tumor, alleviate symptoms, control tumor growth, and maintain quality of life. And I think everyone would agree that those, of course, are reasonable things to try to accomplish. And then we work on a plan based upon all of the treatment options that I discussed previously, and try to come up with a way to try to make that happen. When I first started my career in Nebraska, my first carcinoid patient was a dear friend of one of my colleagues, and he had tumor that was full. He had small bowel neuroendocrine tumor, and his tumor was diffusely spread to his liver. We took out the main tumor to prevent, because he was having some symptoms of obstruction. We did some things to his liver to try to tell him, and then I discussed with him, my goal, of course, is to try to, alleviate some of your symptoms, and then control your tumor growth and maintain your quality of life. I said, your tumor is going to be incurable, but still treatable. I just got a note from his wife just recently that he just passed away after 20 years. Now, mind you, 20 years ago, we had none of the things that you're going to hear about later on, and we had no PRT. We had octreotide, but it wasn't even a proven modality, and we had very few therapies. So I told him part of the goal was to try to, kick the can as far as we can until new therapy, and that's what we did for him for over 20 years. As Hal said, and I'm sure I don't know it was that difficult to admit, but surgery is the most important thing when your tumor is localized. There is no other modality that's out there at this stage of the game that can treat your tumor with potential of even curing you than surgery. Surgery is the only option we have. Other things that we take into account of surgery is obviously where the tumor came from, because that determines what kind of surgery we're going to do for you. And I'll go into the specifics shortly. Size of the tumor matters, and I'll discuss, as Hal mentioned, it matters for pancreatic neuroendocrine tumors. Whether your tumor makes hormones or not is so vital for us as well. And then whether you have disseminated disease or whether there's tumor spread to other organs is a critical factor for determining what kind of surgery we can do for you and how we can do it for you. And as we discussed, the overall health of the patient and their ability to tolerate surgery is vital. Overall, and I'll go into some specifics, unfortunately, once the tumor has spread, it is incurable. It's spread to distant organs. It's incurable, but very treatable. In a fair number of patients who do have surgery, even when we're done for curative intent, do have the tumor come back. And so, as Hal mentioned, surveillance and watching patients for this is vital. And I think that obviously, and to know that we have a plan for what to do in the unfortunate eventuality, if it does recur, is that we do have options for patients. In some patients, prophylactic surgery is worthwhile. So some patients come to me with neuroendocrine tumors of the small intestines, or carcinoids, who don't have symptoms. We do offer them surgery of their intestinal tumor to try to prevent future complications, such as small bowel obstruction, which in my mind is an important factor for the future prognosis and outcome of how patients with carcinoid tumors end up doing. When we try to do symptom control for tumor spread, we try to remove as much tumor as possible. And I'll go into that a little bit as well. We want to get about 80 to 90% of all the tumor. That would really help with tumor burden and help with symptoms. And obviously, I'll talk about liver surgery as well. As Hal mentioned, we can't do anything without having good scans. And I think good scans are still possible with CT scans and MRI. MRI is also our preferred choice for scans, particularly for looking at the liver. But clearly, we've come a long way for other nuclear scans. We used to have the Octria scan or the indium scan, and now we have gallium dotatate, now we have copper dotatate. And just showing you some pictures of some of these images here, I think. So this is the same patient who had an octreotide scan, had a PET scan, and then had a dotatate scan, and you can see each scan looks better, first of all, and you can see the resolution of these tumors significantly improved. You can see all these lymph nodes spread here in the chest. And then, even though we think of the copper dotatate scan, this is patient later on. You can see the resolution of even greater, and I think we tend to use, oops, I don't know why that happens. And now our preferred imaging test, when possible, is to use the copper dotatate scans. Okay, any day now. I do have slides. Okay, yes. Okay. I'll talk specifically now about small bowel neuroendocrine tumors, previously known as carcinoid, or probably the more common name. Obviously, you heard about the delay in diagnosis. I think, it's also important to note that patients often have multiple tumors. About 20% of patients have multiple tumors, and I'll show you a slide of that. Most patients, when they're found to have the carcinoid tumor on a scan, it's not the main tumor that they're seeing. They're typically seeing the spread of the tumor. The main tumor is difficult to see, and I'll show you some pictures of that as well. Now, it's important to note that that spread of tumor that we see on the scan it's very sticky to us during surgery, and things stick to it. Normally, when we operate on patients, we make our incision, we find that the small intestines are freely moving. They float in a little bit of fluid in the abdomen. But when you have carcinoid tumor, the intestines become sticky to the tumor itself, and so there's no movement. So you have some intestines that are moving and some that are fixed, and that's what causes the bowel blockages that plague patients with this tumor. The stickiness can be very difficult to deal with in the operating room. And as such, because of stickiness, I tend to very, very infrequently use laparoscopy as an approach for surgery for patients who have small bowel neuroendocrine tumor. For the reason, because of the stickiness, I really want to make sure I get all of those lymph nodes. And I'll show you the challenges we have with lymph nodes shortly. And for patients who have advanced tumors that are either spread to the liver or they have a nodal spread, then I almost always remove the patient's gallbladder if it hasn't been removed before, because as you heard, triatide or analogs of it are often used modality for the treatment of patients with this tumor, and they are very prone to forming gallstones. Sandostatin and lanreotide affect the way the gallbladder works, and so you are very prone to getting gallstones when you're on this. So as a prophylactic measure, we will remove the gallbladder for such patients. Obviously, I think Hal alluded to it, and I like showing this slide. I think the slide came from Pomier's group, showing the number of different doctors patients have seen prior to a diagnosis of 6, and the number of visits that they've made prior to a diagnosis of almost 12 visits. And so over 50% of patients already have tumor spread when they're diagnosed, as was mentioned by Hal. And I think all this plays into the importance of their management. I won't belabor this, but a lot of patients are often misdiagnosed. Okay. I had to try and find pictures that weren't going to be offensive or too much, for patients or for lay public, and I try not to show some intraoperative photos that may be too much after the good breakfast. So on the left, you can see is the small intestines. This is the large intestines. And the intestines float in the abdomen. There's a little bit of fluid in there, and they move around constantly. But if you were to spread out the intestines, you'd see that there was this yellow leaf-like structure that tethers or connects the intestines to the body. And in this yellow leaf-like structure is all of the blood supply to the intestines. This is how the intestines get their blood. Whoops. And this is how nutrients then get absorbed and go backwards into the veins and other vessels back into the body. This is how the body works. And it's important to note, lymph nodes they live around blood vessels. So whenever lymph nodes there's a blood vessel next to it. So using the same picture, this would be a typical patient who has small bowel neuroendocrine tumor. Here is the main tumor, typically very small, in the wall of the intestines. But what we see is the lymph nodes that are now in the fat. And the challenge is that the density, and the reason why we have this issue, is that the density of the tumor is the same density as the small intestine wall itself. So the CAT scans can't differentiate between the two. But this is fat. This yellow stuff over here is fat. This being so dense, you can see it very clearly. This is a better, maybe a little better picture showing how the blood goes into the intestines, and the lymph nodes live right along blood vessels. Okay, why am I showing you all this? The lights, so I apologize. Hopefully everyone in the back can see. I can take my word for it. This is a mass that does not belong. This is living in that fat, in that yellow area, in that yellow tissue that I showed you before with all the blood vessels. This is the patient's dotatate scan showing activity in this mass. This is a fusion scan, and it didn't light up completely. It didn't overlap completely. But trust me, this is the mass. What you don't see is this is now the main tumor. See that small dot right there next to my red dot? There we go. Obviously, you can't see it on the CAT scan because it's the same density as the intestines, and it's impossible to differentiate. Obviously, this goes to show the value of the dotatate scan in such patients. But this is what when patients are typically found to have carcinoid tumor, it's because they found a mass in the fat of the intestines that prompts further investigation. And it behooves us when we're doing surgery, we have to go and remove the main tumor, but we have to go and remove the blood vessels. I don't know if I have a slide on that. Hold on. Let's see. And that's significant. Remember, lymph nodes live near blood vessels. And so if I have a lymph node that's close to the intestines, I don't have to remove much intestines to remove that lymph node. But if I have a lymph node here, it can be very challenging because if I have to remove all those intestines, that would be almost could be catastrophic for the patient to deal with afterwards. So lymph node location determines the extent of surgery we do, and for the most part, also the risk of the surgery. The farther away it is from the tumor, the main tumor, the more challenging it is for us to deal with. But this is the realities of what we're doing with surgery and the significance of lymph node spread. I like showing this slide. This is a patient who I'd seen prior to having a dotatate scan. And we never really ordered any of the creatine scans. I never found them to be very useful. But in this scan, this is the lymph node spread of the patient right here. And all these white dots are tumors. This patient had over 20 small bowel neuroendocrine tumors feeding this lymph node area over here. We had to take out a fair amount of small intestine, but enough for this patient to have a great quality of life. And we were able to remove those lymph nodes, and she's still doing very well. But I showed this slide because one of the things it's hard to do laparoscopically is find all of these small tumors. Now, I don't get this test anymore because of the dotatate scan, but the ability to find all those tumors is very challenging laparoscopically. So I think for laparoscopic surgery for small bowel neuroendocrine tumors, I tend to use very infrequently. What about pancreas, the other main tumor for which surgery is used for often? Now, probably will contrast this to small bowel. Many of the things that apply to small bowel neuroendocrine tumors also apply to the pancreatic neuroendocrine tumors, except for certain things. I'll explain it in a little bit. One, we use endoscopic ultrasound. Endoscopic ultrasound is a modality that allows us to put an ultrasound probe into the stomach and then scan the pancreas. We're able to determine and detect really small tumors that way, something we can't do for other neuroendocrine tumors. Once again, it's the only possible cure for patients with pancreatic neuroendocrine tumors is surgery. And obviously, of the same factors that we use to determine what kind of treatment options you have for pancreatic neuroendocrine tumors exist for small bowel neuroendocrine tumors, with the caveat, of course, is I do think that the genetic component is critical. Some of these pancreatic neuroendocrine tumors have a genetic component, and their natural history or biology is different than those that don't have a genetic component. And obviously, I think that some of the surgery options for pancreatic neuroendocrine tumors tend to be more um, more complex, more lengthy, and more risk. So the overall health of the patient then becomes an important factor as well. I like showing this next slide. This was a patient who also came to me in my first year of practice. And she had a rare pancreatic neuroendocrine tumor resected about 25, 30 years ago. And she comes to see me and she says, my tumor has come back. And I said, okay, where are your scans? She says, I don't have any scans. And I said, well, how do you know your pancreatic tumor has come back? There's no scans, naive surgeon. I was like, I need scans, I have to do something. And I was like, well, how do you know it's come back? And so she lifted up her shirt. Any day now, any day. Sorry about that. And she showed me her rash. And she had a rare pancreatic neuroendocrine tumor that causes this kind of a rash. And she said, oh, it's back. I said, yes, it is. And if you make out, you can see her old scar from her previous pancreas operation. So, I use this slide often to teach students and residents about the importance of listening to the patient and trying to get a good history from them. But obviously, we got a scan right after this demonstration, and sure enough, her tumor had recurred in her liver, and we treated her. And as we treated her, her rash went away. Oops. Okay. Now, when it comes to pancreas surgery, it's all about location. Where the tumor is located will determine greatly what kind of operations we can do. In addition to that, size is also an important factor. What I didn't show here and want to convey as well is that next to the pancreas are a significant number of blood vessels, and involvement of those blood vessels also change how we deal with it. But in general, we pretty much have three options. If you have a large tumor in the head of the pancreas, or this portion of the pancreas, you require a operation affectionately known as a Whipple operation. If your tumor is not in the head of the pancreas, then we just take out half of the pancreas, this half. Your spleen's over here too. Apologize, I didn't show it here. If your tumor is small and on the edge, we can on occasionally just shell it out or pop it out. And that's called a nucleation. Now, as opposed to carcinoid or small bowel neuroendocrine tumors, where I don't tend to use laparoscopy, in contrast to pancreatic neuroendocrine tumors, I almost always use laparoscopy. It doesn't create the same stickiness, and we don't have some of the same issues with the lymph nodes like we do for the small bowel neuroendocrine tumors. And to go beyond laparoscopy, we started using robotics. Now we typically, in our practice, we do all our pancreatic surgery of all kinds. We do it all robotically. And a lot of patients come to me and say, well, what's this robot thing? And the robot allows us to do operations or to do things laparoscopically that we couldn't otherwise do. I like showing this gimmicky video. Just it's a movie, and who doesn't like watching a movie? Oops. Can you hit play on the screen? Is that possible? Thank you. So we're controlling the maneuvering of the arms on this robot. So it's not the robot. There's no independent action. It's us doing it. And then this is showing us peeling the layer of a grape off, and then suturing it back on. And so these are the things that we can do. This would be extremely challenging to do laparoscopically. Very difficult, but very manageable robotically. And hence we do almost all of our pancreas operations robotically. As Hal said, typically when we have tumors that are over 2 centimeters in size in the pancreas, we tend to offer them surgery. But what do we do for the patients who don't have tumors who have tumors less than 2 centimeters in size? They can be very challenging or controversial and difficult to manage with patients. This is a 76-year-old female who came to us with a very small 9 millimeter neuroendocrine tumor. She's otherwise healthy. We opted for her to go under observation. We knew we did a biopsy. We knew it was a neuroendocrine tumor. We knew it was low grade, and we decided to watch. And she's doing great. And about 4 years later, her tumor is unchanged, still the same size, and we just watch her. So observation is a option for patients in the right circumstances. I like showing this slide. This is an 82. She was 82 when she came to see me, and she came to see me with a suitcase. And I thought maybe she came from far away and she was traveling, but no, she was just like 5 miles down the road in Long Island. She comes in and she says, I had this tumor. She had a biopsy of this neuroendocrine tumor shown by the arrow, and she says, I want surgery. I want surgery today. And she brought her suitcase. I said, okay, well, I can't do that. That's not possible. Today, I always tell patients that yesterday and today are the only 2 days I can't operate. Tomorrow is different, is always an option. But so today was not an option for her. But she was insistent on having surgery. And she's like, I'm 82. I don't want age stopping me. This is, I've got grandkids and so forth. She's got plans, and she was very active and very functional. So after talking to her educating her about neuroendocrine tumors, she had forgotten, but 10 years ago, she had a CAT scan for some unrelated issue. And lo and behold, our radiologist looked at the scan and found the tumor there 10 years ago. So I bring her back. She still brought her suitcase because she still wanted the surgery. And I said, well, this tumor was there 10 years ago, unchanged. He said, what, really? Really? Yep, 10 years ago. I couldn't prove it. I don't have a biopsy. But our radiologist said, nope, the tumor was there, just not easy to see on the better quality scan that was obtained earlier, more recently. She said, okay, well, in that case, why do I need surgery? I said, exactly. We just have to watch you. We've been watching her ever since, and the tumor hasn't changed. Another patient for whom surgery observation was a great option for. Typically, we don't really give observation for patients who have a liver or liver spread, although that's not always necessarily true. But we tend to typically formulate a plan for what to do with them. As Hal mentioned, about 50% of patients will either have liver metastases or spread at the time they're diagnosed, or will develop it at some point in their disease course. Well, our options include debulking, removing part of the tumor, which can really improve survival, can improve quality of life. My philosophy with regards to neuroendocrine tumors that have spread, in general, patients, when they succumb to their tumor, succumb to tumor from tumor spread in the liver. You need liver, and as the tumor replaces your liver, as you have less and less liver, that's when life becomes challenging, and that's how patients typically succumb. The one exception, of course, is for the small bowel neuroendocrine tumors, where you can have problems with bowel obstruction. But if you don't have problem with bowel obstruction, patients typically don't die from spread to lymph nodes in the chest. They're going to die from spread of disease to their liver. So in my mind, it's all about controlling the liver. And we want to do so with sparing as much normal liver as possible. So if I have a patient who has a small spot in the middle of the liver, I'd be very loath to remove half the liver just to get that one small spot, because I've just taken out a whole bunch of healthy liver. But in this patient had a very large tumor in just the right side of the liver, occupying her whole entire right side of the liver, with her left liver completely spared, I think one small spot there. Now this patient had a very rare pancreatic tumor that resulted in her having 20, 30 bowel movements a day. We took out this tumor and removed that one as well. her bowel movement problem stopped, and I think she was going to she wanted her kids to name her grandkids after me because her life had come back. She was able to do the things that she wanted to do, and her family was so grateful because now she can go to birthday parties, she can drive places, she can go to events that she couldn't go to otherwise, all because we helped with her symptoms. And probably did extend her life, and although she did end up passing away, she actually had to pass away from something else unrelated to her tumor, which is something I also try to tell patients. Our goal is for, if we can't cure them and we can't cure her, is for her to live long enough so that she would die of something else. That would be a desired goal. But we do have other options besides surgery for some patients. And so this is a patient who has a large pancreatic neuroendocrine tumor. And although I'm only showing one spot in the liver, this patient had 2 other spots in the liver, all amenable to surgery and to, quote unquote, debulking, removing this tumor and moving the other spots. This would be a great patient for a surgical option. This patient, however, is not. You can see, you probably, even in the back of in the room, can probably count at least 10 to 15 spots in the entire liver. All these spots are tumor spots. So there's no surgical option for this patient. We can't remove all these spots and leave enough liver. But there still are options for this patient. I like showing this slide, and I'm so glad that you can't read it. I really am glad that you can't read it because the content isn't critical. And the content goes to what Hal had mentioned before, and that is the treatment options that are available for patients with neuroendocrine tumors. You saw all the options listed, and the algorithm can be quite complex. And so I like to show on the right, on this part of the screen, is the algorithm for managing pancreatic adenocarcinoma. You can see it's relatively simple. You have, if you're in this group, you get option A. If you're in that group, you're eligible for option B or C. That's it. Whereas for pancreatic neuroendocrine tumors, look at all these options, and this is an oversimplification of the management. It could be quite complex. And so another reason why patients come to me and say, well, I know so-and-so who has this, and they got that. Well, so-and-so didn't have your exact tumor with your exact location and your exact symptoms or hormonal production. And so it's very difficult to compare patients when they have such diversity of symptoms, tumor location, as well, and size. It's just too many factors involved to try to make comparisons. And so I know it's very common, very easy for patients to go on and to speak to one another. But when they have such diverse features, it makes that kind of discussion very challenging or difficult. And so each patient, as Hal said, is unique and is discussed typically in our location with a large group of physicians to try to make the best plan for them. And each patient tends to be with almost a different plan. It would not be uncommon for us to discuss 3 patients, some similar features, and to offer them 3 different options. Each patient a different option. And with that, I will stop and I'll be available for the Q&A, so thank you.